our first topic that we're going to cover is the calcium channel blockers. First of all, what you should know is basically the concentration of the calcium inside the cell is 0.1 micromole per liter, comparing to 2 millimole per liter outside of the cell, which means if we had a channel, a calcium channel opened in the cell membrane, this means that there would be an influx of the calcium, right, according to the concentration gradient. This is the first information you know about calcium. Now, the second thing, whenever you hear the word calcium, three things should come into your mind. This is going to be important in the other topics that we're going to cover later on as well. The first thing is the muscle. So the calcium is an important thing for the muscle contraction and the neuron. It is very important for the neuron function, conduction, and also the secretion. And this includes both the exocrine and the endocrine secretion. Okay, now so let's move into the types of the calcium channels. We have actually 5 types of the calcium channels that we're going to cover: the voltage-gated calcium channel, the ligand-gated calcium channel, the ryanodine receptor, the calcium pump, and the Ip3 receptor. Now, starting with the voltage-gated calcium channel, which is the most related to our topic, and actually the most related voltage-gated calcium channel is the L type that we're going to cover, but let's actually go through all of them. Now, we have the L, the N, the T, the PQ, and the R types of the voltage-gated calcium channels, and well, as you all know, that basically most of the voltage-gated channels in general, they actually open when there is depolarization in the membrane, right? So we have these types of the voltage-gated calcium channels, and we're going to compare their activation threshold, and we have the inactivation. So these arrows that you see here, they actually demonstrate the activation. So the L-type voltage-gated calcium channel, they have an activation threshold that is very high, which means that the action potential that is going to happen in the membrane that is causing the depolarization should actually make a high positivity inside the cell to activate the L-type, comparing to the other voltage-gated calcium channels that actually their activation threshold is actually much lower than the L-type. Now, going to the inactivation, now the inactivation, which actually means like how fast is the channel gonna close after being opened due to the activation. So it is going to be slow in all of them except for 2, which is the T-type and the R-type. Now, why is it actually fast in activation in the T-type? You may just think about it because the T-type is present in the atria, in the SA node, and we need a fast inactivation because we want to start a new activation since it is important for the heart rate. So if you have like 70 beats per minute, well, you have to inactivate it and activate it really fast. So basically the inactivation is fast in the T-type. Well, it's worth mentioning where actually these guys are. So the L-type voltage-gated calcium channel is present in all types of muscles, including the skeletal, the smooth, as well as the cardiac muscles. Now the N-type is present in the neurons, the T-type is present in the SA in the atria, so the sinoatrial node in the atrium, and the PQ is basically present in the nerve terminal. Now we have actually some blockers for the N and the T and the PQ. It is actually, well, I don't see any importance in my experience, but I mean, yeah, it's worth mentioning. So the N-type can be blocked by the conotoxin, and you can see like maybe it's gonna help the N here and the N here, conotoxin. The T-type is gonna be blocked by the mibifradil, and the PQ is the agatoxin. Anyway, so jumping to the second type of the calcium channels is the ligand-gated. Now, in this type, it's basically a receptor that is gonna be bound by a ligand, and this ligand is going to lead to the activation of the receptor. The activated receptor is going to open a channel of ions, and this ion here is the calcium. Now, what kind of ligand is it? It can be like the ATP receptor, so the ligand is ATP, the glutamate receptor, so the ligand is glutamate, and the acetylcholine nicotinic receptor. Well, it is not really specific for calcium, since we know that in the neuromuscular junction, for example, the acetylcholine nicotinic receptor is not specific for any cation. It actually it allows the sodium, the potassium, and the calcium influx, although the sodium is the highest. But yeah, so it is just an example. Anyway, so jumping to the third type is the ryanodine receptor. Ryanodine receptor is present only in 2 types of muscles, the cardiac and the skeletal. So it is a very huge mistake to say that the ryanodine receptor is present in the smooth muscle, since the mechanism of contraction in the smooth muscle is a little bit different. The third type of the calcium channels is basically the ryanodine receptor. Now, in the ryanodine receptor, okay, so look at this figure. It is basically a neuron terminal here, and this is the neuromuscular junction. So this is the sarcolemma, okay, so the membrane of the muscle, and here should be the nicotinic acetylcholine receptor at this area, and this is the T-tubule. Well, the T-tubule is only the skeletal muscle, but this is just to make it a little bit more understandable. So basically, we believe that there is a protein complex connecting the T-tubule with the sarcoplasmic reticulum, which actually is the storage of the calcium in the muscle. And whenever there is an action potential running through the membrane of the muscle, this protein complex is going to lead to the activation of the ryanodine receptors that are present in the sarcoplasmic reticulum and allow a calcium outflux from the sarcoplasmic reticulum into the cytoplasm. So basically now the calcium concentration is increasing inside the muscle to help it contract more. Now, the fourth type is the calcium pump. The calcium pump is like a reverse type of the ryanodine. So basically after the muscle has contracted and after the calcium concentration in the cytoplasm has been increased, now we should actually put things back to the resting phase. So the calcium pump is basically using ATP and using ATP hydrolysis to ADP, pumping the calcium back into the sarcoplasmic reticulum. Now, why does it use ATP? Because we know that the sarcoplasmic reticulum is the storage, which actually means that it has a higher concentration than the cytoplasm, even when we increase the concentration of the calcium in the cytoplasm, right? So we need ATP to pump the calcium back into the sarcoplasmic reticulum and reform the resting phase. Now, the fifth type of the calcium channel blocker is the Ip3 type. Now, the Ip3 receptor is present also in the sarcoplasmic reticulum. The activation of the Ip3 receptor is by the Ip3. Now, the Ip3, if you remember from biology, is basically formed when there is an activation of a GQ receptor. So basically it is a metabotropic receptor, okay, like the angiotensin and the noradrenaline receptor and the histamine receptor. So these receptors, they are GQ. This is going to lead to the production of the Ip3. The Ip3 is going to swim in the cytoplasm and reach the sarcoplasmic reticulum membrane, where actually there is an Ip3 receptor. The Ip3 is going to bind to this receptor, lead to the activation of it to enhance the outflux of the calcium from the sarcoplasmic reticulum into the cytoplasm, increasing the concentration of the calcium in the cytoplasm to enhance the contraction of the muscle. So these are the types of the calcium channels in general. Now, so let's move to how does the smooth muscle actually contract. Now, so out of all of these, we have the L-type voltage-gated calcium channel. If you remember, I said that the L-type is present in the three types of the muscles. Anyway, so we have the L-type and we have here a GQ receptor. This one is present also in the smooth muscle membranes, which is going to lead to the production of the Ip3, activation of the Ip3 receptor. Calcium concentration in the cytoplasm is going to be increased by both by the voltage-gated calcium channel and also by the Ip3 from the sarcoplasmic reticulum, enhancing the calcium concentration, which is going to activate the calmodulin, which is basically the calcium binding protein, and this is going to lead to the activation of the myosin light chain kinase that is going to lead to the phosphorylation of the myosin heads, and the myosin heads are going to lead, when they are phosphorylated, this is going to lead to the contraction of the smooth muscle. Basically, the calmodulin activation of the myosin light chain kinase is also by phosphorylation. So when you see a myosin light chain kinase that is phosphorylated, this is active. Dephosphorylated is inactive. Okay, moving to the what is the target? I mean, if we block the calcium channel in the smooth muscle, like why would we do that? Because we would actually result in vasodilation and bronchodilation. So we are inhibiting the contraction of the smooth muscle that is present in the vessel, leading to vasodilation, and in the bronchi as well, leading to bronchodilation. Moving to the cardiac muscle. Now the cardiac muscle, as we said, that it has a ryanodine receptor in the sarcoplasmic reticulum, and it also has the L-type since it is present in all types of muscles. Now, so both of them are going to enhance the calcium concentration in the cytoplasm, but here it is different, since actually the calcium is going to bind to the troponin C, and the troponin C is going to lead to the contraction of the muscle. Now, if we block the calcium channels that are present in the cardiac muscles, this is gonna lead to the decrease in the contraction and decrease in the conduction, decrease in the heart rate. So what does that mean? This actually means that we are decreasing the oxygen demand of the heart. Okay, so like, and as you know, that for example, the angina is like a shortage of the oxygen supply that is happening, right? So basically, we decrease the oxygen demand by decreasing the contraction. This is just one example of the usage of these drugs. So, in the skeletal muscle, what will be the effect of the calcium channel blockers on the skeletal muscle? It's nothing, since actually the skeletal muscle has a huge store of calcium in the cytoplasm. So basically, even if you block the calcium channels that were meant to increase the concentration of the calcium in the cytoplasm, this is not going to lead to any effect, because actually there is already a high concentration in the cytoplasm in the skeletal muscle. So do the calcium channel blockers block the calcium channels in the skeletal muscle? Yes, but it doesn't have a consequence. That's the conclusion. So going back to the L-type voltage-gated calcium channel, basically the L-type voltage-gated calcium channel has 5 subunits. Okay, 2 alpha, 1 beta, 1 gamma, 1 delta. Now, if we thought of it like to have all of these subunits right next to each other, okay, our drugs, the calcium channel blockers, are gonna only bind to the alpha 1. They don't bind to the alpha 2 or beta or gamma or whatever. They only bind to alpha 1. This is actually worth mentioning. This is one thing. The other thing that basically when we compare the VERAPAMIL later with the dihydropyridines, they actually bind differently on the alpha 1. Since the VERAPAMIL binds to the intracellular domain of the alpha 1 of the L-type voltage-gated calcium channel, while the dihydropyridines they actually bind from the extracellular domain of the alpha 1 of the L-type voltage-gated calcium channel. Okay, now are they antagonists? No, they are not antagonists, because we're not talking about a receptor. We're talking about a channel that is voltage-gated, which actually means that it is an ionotropic. It is not metabotropic, so we can't say that they are antagonists. Okay, so if they are not antagonists, what is the mechanism then? The mechanism is physical block. So basically the drug binds to the alpha 1 and it really inhibits the calcium from entering into the cell. So now what is the general indication of the calcium channel blockers? We have an important function on the heart, the brain, the blood, and in the P170. Now, in the heart, we know that it's going to end up decreasing the oxygen demand. We're going to talk about it. And in the brain, whenever there is a vasospasm, decrease in the blood supply to the brain, so we can actually use the calcium channel blocker to help actually relieving that. And we know that if there was an ischemic stroke, we can also decrease the damage that is going to happen by the ischemic stroke by using the calcium channel blocker. And in the blood, well, we have 2 main things. We know that the calcium channel blockers can actually lead to the vasodilation by inhibiting the calcium channels in the smooth muscle. So if we do that, we actually can help the hypertension. This is on one hand, but on the second hand, we know that in the coagulation cascade, we need the calcium. In the activation of, for example, factor 10 and so on, and other factors as well. So calcium is really important for the coagulation. So by this, we also decrease the coagulation of the blood. In P1 and also the platelet coagulation, since actually the platelets coagulation needs calcium. Now the P170 is basically a multi-drug resistance. This is a kind of pump that would be in the cancerous cells in order to pump out the drugs. So that's how the cancer actually will stay living even if you are treating it and is resistant to many drugs, because when you give the drug can enter the cancerous cell, but the cancerous cell is smart enough to pump it out again. And this is, for example, the P170 and the calcium channel blockers can actually block it. Anyway, now let's actually go to what drugs do we have in this category. Now the first one is the VERAPAMIL. It is very important calcium channel blocker, since it is actually a cardiac muscle calcium channel blocker selective. So it only blocks the calcium channels that are present in the cardiac muscles, not in the smooth muscles. So what would happen if we blocked the calcium channels that are present in the cardiac muscle? In the SA node activity, it is going to decrease, the AV conduction is going to decrease, and there is going to be a negative ionotropy. Okay, so what if all of these happen? What is going to happen? There is going to be decrease in the cardiac output, and there is going to be decrease in the oxygen demand of the heartbeat, since we are actually decreasing the heart rate and we are decreasing the force that the heart is contracting by. So basically, according to that, we can indicate the calcium channel blockers to treat the tachycardia, as well as the arrhythmia and the fibrillation and the effort angina. Now we're talking about the stable angina, where actually there would be like atherosclerotic plaque that is just decreasing the radius of the coronary arteries, and the re-entry, which is another type of arrhythmia. So we can use the VERAPAMIL as indication for these diseases. Now, another thing, that if we use a very, very high dose of the VERAPAMIL, there will be actually a decrease in the insulin secretion from the beta cells of the pancreas. It is just worth mentioning. Now, the second one is the dihydropyridines, the DHP. So you would actually often see this DHP. And the dihydropyridines, comparing to the VERAPAMIL, they are actually vascular smooth muscle selective. So they don't work on the heart. They work only on the vascular smooth muscle, or mainly on the vascular smooth muscle. But they also have a function actually on the smooth muscles that are present in the bronchi as well as in the GI and the uterus, and maybe they are indicated in the IBD, which is the irritable bowel diseases, or the inflammatory bowel diseases. Okay, so basically we can indicate it since they all have smooth muscles, but what we are talking about and what we're focusing about in this topic is the vascular smooth muscle selectivity. Now, what do we have in this category? The dihydropyridines are the nifedipine, nicardipine, nitrandipine, nimodipine, nizodipine, amlodipine, philodipine, isradipine, and lacidipine. So we said that they are smooth muscle selective. Now, so if they are smooth muscle selective, they are going to lead to vasodilation. Now, vasodilation means that we can use these guys to treat hypertensive patients on one hand. On the second hand, we can use it to treat the prinzmetal angina, as we know that the prinzmetal angina is this sudden contraction in the smooth muscles of the coronaries. It is a sudden vasospasm, and this is basically because we have more alpha receptors than beta receptors in the coronary, or I mean that these patients have more alpha receptors than beta in their smooth muscles of the coronary arteries, and well, so we can just block the calcium channels of the smooth muscle and inhibit the contraction at all, right? Now, we didn't use the dihydropyridines for effort angina. We used it for the prinzmetal angina. Now, why? Then, for example, if we use the nifedipine for effort angina, and we know that the effort angina is basically that we don't have enough oxygen supply to the heart to do its function. If we use the nifedipine, this is going to lead to drop in the blood pressure. The drop in the blood pressure is going to lead to reflex tachycardia. So the heart is going to try to increase the heart rate in order to compensate this hypotension, and this is just going to make things worse, because now we need even more oxygen when we don't even have the basic oxygen supply for the basic heart function. Okay, so that's why we should actually be really careful in dosing the nifedipine for an effort angina, or we may just use the VERAPAMIL and that's it. The other indications are the vasospasm that can happen after the subarachnoidal hemorrhage, and in this case we use the nimodipine. There is also the pulmonary hypertension and the progressive sclerosis. Now, the third category here is the diltiazem. Our friend, the diltiazem, is actually selective for both. It is just friendly with both the cardiac muscles as well as the smooth muscles. And we can use the diltiazem as well as the nifedipine actually in the Raynaud disease, where we actually get these very wide fingers due to the vasospasm of the arteries supplying the fingers, and we can just resolve that by using the diltiazem as well as the nifedipine. Now, what are the side effects of the calcium channel blockers? So, we said that the calcium channel blockers are going to act on the heart and decrease all of this, right? Decrease the contraction, the conduction, and so on. What if this has happened more than needed? This can actually lead to depression of the ventricle. This can actually lead to bradycardia. This can also lead to block of the AV. So if we decrease the conduction in the AV, what if it has happened more than needed? This can lead to an AV block. Now, the torsade de pointes is basically this very lethal arrhythmia that can develop due to the use of calcium channel blocker. And I know, like, this doesn't really make sense, since we actually use the calcium channel blocker to treat arrhythmia. How comes that they can cause arrhythmia? Yes, they can cause arrhythmia because they are actually not that selective to calcium channels, or let's say that they are selective to calcium channel but not that selective. Why? Because they can actually block some potassium channels and some sodium channels as well, and can end up causing arrhythmia. So the drug called the piperidine has been withdrawn because it has blocked so many potassium and sodium channels, and too many patients who have used the piperidine have developed arrhythmias, and that's why it has been withdrawn. Now the other side effect is the hypotension that can develop, leading to a reflex tachycardia that we've mentioned already, and the flushing. So imagine just vasodilation in the cutaneous vessels, dizziness and constipation can also develop due to the calcium channel blockers. Now, what about the pharmacokinetics of the calcium channels blockers? Yeah. Now we know that these drugs are given orally on one hand, and on the other hand that basically they have a very high first pass metabolism, which actually means that the liver is going to decrease the dose so much before reaching the systemic circulation. And the more important about the pharmacokinetics about these drugs is that the VERAPAMIL has actually a very, very high plasma protein binding, making actually a lot of interactions with other drugs that actually have a high plasma protein binding. So we should be really careful applying VERAPAMIL with other drugs that have high plasma protein binding. And yeah, so the elimination of these drugs also happen in the liver by metabolism, so it is basically extensively in the liver, and then the metabolites are going to be eliminated by urinary excretion. So I think that's all about the calcium channel blockers. I hope that you guys have found this video really helpful, and you can just leave me your opinion about the video in the comments.